It's a real privilege to be here and to be asked to speak. It's a bit intimidating because I know you already all know so much about PCO anyway, so I hope I have one or two things that are new for you, but please feel free to correct me where I'm wrong. Jean Hailes has already done so much groundbreaking work on PCO as it is that I've decided to heavily reference the guideline documents and also the GP tool, which I think can be really helpful. So, what is PCOS? It's actually hard to find a concise definition. This is one taken from the guidelines, that it's a chronic condition with manifestations that begin most commonly in adolescence with menstrual irregularity and hyperandrogenism, with transition over time into problems including infertility and metabolic complications. So that does really describe it in a nutshell. But we know that it's a heterogeneous condition, so we know that the etiology is poorly understood. We know that there are multiple symptom types and there seem to be multiple phenotypes of women presenting. And you see that, I'm sure, in the clinic, some women fit all the criteria. They've got terrible hirsutism and acne, they have amenorrhea, problems with weight, all the rest of it. And then you'll find someone else who has quite mild menstrual irregularity and maybe a few cysts on their ultrasound. And they're clearly quite different in their presentation and management, but they all come under the one umbrella term. So I've gone just a little bit into etiology, and this again is from the guidelines, and I think that it's something we're all pretty familiar with, that certainly lifestyle is important and obesity, but I think what's often forgotten is that genes are a very strong component. So there are various different estimates, whether it's between 40 and 70% is perhaps attributable to the genetic component, very much akin to type 2 diabetes. So there are plenty of obese women out there who do not have polycystic ovary syndrome. There are plenty of women with PCOS who are not obese. So genes clearly play a very strong factor. Often it runs in families, so a woman with PCOS may have a mother or a sister or an aunt who's got polycystic ovary syndrome, or they may have a family history of type 2 diabetes, so they're quite closely related. And this combination leads to the hormonal changes. And the key changes that we really look at are an excess of androgens, so this is excessive production of androgens from the ovaries, and also to some degree from the adrenal glands, and insulin resistance. And insulin resistance and hyperandrogenemia really interact to drive each other, and the insulin resistance has a direct effect on the ovaries and also all these other risks. The ovaries seem to respond to the insulin differently to someone who doesn't have PCOS. Insulin resistance seems to be a core feature, and even very lean women with PCOS have a degree of insulin resistance. So it's called an intrinsic insulin resistance. It's not, we know that weight will make it worse, but it's not necessarily because the person is overweight, they just have an intrinsic insulin resistance. I think insulin resistance is an interesting phenomenon. I think in medicine it's a dirty word, but it's actually evolutionarily a highly conserved mechanism. It is found in all kinds of organisms, including flies and other invertebrates, mammals. It has an adaptive mechanism, so it's really designed to reprioritise nutrients away from low priority tissues toward high priority tissues. So for example, in pregnancy we have insulin resistance, and that directs nutrients towards the fetus. In infection, insulin resistance is part of that pathway, and it allows the body to prioritise the inflammatory and immune response and fight off infection. It's also protective in starvation. So I think that the way I look at it, which is maybe not completely scientific, is that, up until perhaps a few hundred years ago, insulin resistance in a lot of these women would have been highly advantageous. So if they were fighting chronic infections without antibiotics or low food supply, they were probably going to do quite well compared to peers who didn't have a degree of insulin resistance. Now it is a spectrum, and in the modern day it's not necessarily a really helpful thing, but I think it's helpful to have just a different perspective, and sometimes I think for women in the clinic it's helpful to have a bit more of a positive spin as well. The difficulty is, of course, is that as well as having an evolutionary protective side to it, The downside of insulin resistance are really the metabolic complications. So we know that insulin resistance can progress towards pre-diabetes and then type 2 diabetes. And inflammatory insulin resistance, so insulin resistance and also the immune activation that often accompanies it, plays a strong role in the development of other chronic cardiometabolic conditions, so cardiovascular disease, etc. So I think it's quite complex. I think there's a lot that's still not known, which is what can make it quite hard to manage in the clinic. This is a little table pinched from Up to Date, which just shows some of the candidate genes that have been suggested to be linked to polycystic ovary syndrome. And I've just put them up just to give you an idea of how broad it is and how many systems are involved. I certainly don't know this list, but it's certainly not a simple disorder. It's really, when you talk about the genetic load, it's really similar to a scenario with diabetes or heart disease, in that we're looking at multiple sort of polygenic disease rather than there being one particular gene. The genes that have been linked to it involve a whole range of different systems. So, you know, we've observed that in PCOS, for example, the LH amplitude and frequency is higher, and there certainly have been some genetic linkages to areas that code for luteinizing hormone. There's also genes linked with insulin and various other aspects. So, for example, genes that code for sex hormone binding globulin, but also a whole range of other genes. So I think we really don't know. There's so much we don't know, I guess is what I mean. And hopefully, as we get more information, we're going to be able to categorise various subtypes of women better and come up with better treatments for them. So I like this slide a lot. This is from the GP tool, and it really gives you pretty much all you need to know to diagnose PCO. I think, and I like here, they've got the epidemiology of it. So it's a very common disorder, 12 to 18%, or some maybe 21% higher in certain ethnic groups. So I thought we'd just go through this page in a bit more detail. So the prevalence we know is high. We know there are certain ethnic groups where it's much more common, so a very high rate in Indigenous women, probably more like 20%. And it's more common in the groups that you typically see diabetes in as well. We tend to use now the Rotterdam criteria, so there's been multiple variations of diagnostic criteria over the years, which I don't think is worth going through again, because I think at the moment everyone's pretty much settled on using the Rotterdam criteria, and this is because it's extremely broad. I mean, if you've in any way got PCO, you'll fit into these categories. And the Rotterdam criteria really say you've got PCO if you've got 2 of oligo or anovulation, which is basically irregular periods, clinical or biochemical hyperandrogenism, and ultrasound findings of polycystic ovary syndrome, and you've excluded other causes. So in a lot of ways, it means that PCO can be made clinically, the diagnosis can be made clinically. You don't always have to have a whole battery of investigations. So oligo or anovulation really means irregular cycles. So if a woman's got cycles that are less than 21 days or more than 35 days, you call that menstrual irregularity or anovulation. So this criterion, you're really determining on history. The difficulty comes when you're talking about adolescents. Adolescents are very difficult to categorise, and often you can't really make the diagnosis until they're a bit older. This is a suggested menstrual cycle length for categorising whether or not an adolescent does have oligoanovulation. Adolescents can present to you, adolescents with PCO may present as primary amenorrhea, although that's not that common. They may have secondary amenorrhea, so their period started and they haven't come back. But more frequently, they've got this sort of oligomenorrhea. And it really depends on how long it's since menarche as to how irregular you decide their periods are. So for this suggested guideline, you know, when you're looking at 4 years post-menarche, the average cycle length to be called regular is more than 45 days. So it's quite different to what we would think about in adults. So I think that it's useful keeping it in mind, but it's why it is quite difficult to make the diagnosis in teenagers, and why sometimes you have to sort of follow them a little bit over time. The second criterion is biochemical or clinical hyperandrogenism. So clinical hyperandrogenism, as we know, is acne, hirsutism, androgenic alopecia, and I'll show a couple of diagrams in a minute. Or it may be biochemical hyperandrogenism. And sometimes this criteria creates a little bit of confusion because, someone will be referred and the gynae or the GP will say, but their testosterone is normal, so what does it mean? And actually a lot of women will have normal androgens, and it doesn't rule it out. It's really, do they have the clinical features? And we don't really have a great explanation for why you would have normal androgens and yet clinical hyperandrogenemia. It may be a different sensitivity to androgens at the level of the skin. There's also current speculation that there may be as yet uncharacterised androgens. So there's a new androgen that's been described in a couple of labs in the US, but that's still yet to be confirmed. So that's another possibility as well. But certainly we do see quite a number of women who have quite severe hirsutism and acne whose androgens aren't that remarkable. The other thing is often if you look at the total testosterone, it might look normal, but actually their sex hormone binding globulin is very low. I think I've got that on the next slide. So androgens are very tricky to measure. It's very lab dependent. And it depends a lot on the assay that's used. I tend to measure total testosterone and SHBG, and that allows them to calculate the free testosterone. SHBG is sex hormone binding globulin, so this is a protein that's made by the liver, and it binds to sex hormones, in particular testosterone. If you've got a very low SHBG, it's generally indicative of insulin resistance. It also means that whatever testosterone you have is more likely to be free or bioavailable, so it's more likely to have an action on your end tissues, so your skin and your hair. So someone could have a normal total testosterone but a very low SHBG, and they're quite likely to get androgenic symptoms. This is the modified Ferryman-Galway scoring system. Now, I don't use this, I don't think anyone clinically uses it, but it's just quite useful. It's a rating system for hirsutism, and I've just put it up because it shows you some of the degrees of severity and also the distribution of hair that you're looking for, and this is also where you look for acne as well. So classically, it's upper lip, it's chin, sometimes it's around the breast, often it's in the midline of the abdomen, and the lower back in particular as well. So these are just good areas to have a look for hirsutism. And I always ask them as well, how often do you shave, wax or pluck? Because often they've treated themselves pretty well with their cosmetic therapies. It's very hard to see, but then they tell you, oh, actually I shave my chin every day. It gives you an idea of severity, and is also quite helpful for monitoring the success of any treatments. And the third criterion is polycystic or radiological findings, so polycystic ovaries on ultrasound. So the classic definition has been ovarian volume of more than 10 cc's in the absence of a dominant follicle, and or more than 12 follicles in at least one ovary. The caveat, which is in our little toolbox here, is that this is really for women over the age of 18. So ultrasound generally in ovaries is very unreliable in adolescents because cysts on ovaries are so common. There's been debate about should the criteria be different, so should it be more than 17 follicles in an adolescent? Should the volume be more than 12 cc's? But I think the consensus at the moment is that it's really not useful for the diagnosis in adolescents. Where you might use it in an adolescent is if you're worried about some other ovarian pathology. And also, although we usually use vaginal ultrasound, you can use transabdominal ultrasound. It's not quite as accurate, but in someone who really doesn't want it, where it's not appropriate, I don't think we should force women to have a transvaginal ultrasound. And to make the diagnosis, often you don't have to have an ultrasound. I think different practitioners vary in their practice, but technically to fulfil the criteria, if they've got irregular cycles and they've got hyperandrogenism, you don't have to go on and get the ultrasound. So it depends what you're doing the ultrasound for and what you think it's going to yield, or if you're worried about something else. This is just a little diagram of an ovarian ultrasound. So here we've got a normal ovary with the developing follicles in the black here, and this is a polycystic ovary, just showing the multiple very small follicles scattered throughout. The classic description is string of pearls, so if you Google it, you'll get lots of images of very enlarged ovaries with all these follicles around the outside, but in practice you often don't see that. I guess one of the most important criteria is excluding secondary causes. This often feels like you're flogging a dead horse in practice because it's so rare, really. Most people that present with PCOS are going to have PCOS. But it's still worth thinking about, well, what could be other causes of irregular cycles? And I've put a few of them up there. Sure there's more. So thyroid is classic, hyperprolactinemia. There may be cases where you're worried about early menopause, but they'll usually have a whole range of other classic symptoms. The rare one that people worry about is Cushing's, which is also a cause of hyperandrogenism. There may be other things that you're worried about, like hypothalamic amenorrhea. It really depends on what symptoms they're presenting with. In terms of hyperandrogenism and irregular menses, the other things we think about are non-classical adrenal hyperplasia, which tends to present later in life, androgen-secreting tumours, which again are rare and generally associated with a rapid progression of symptoms. And another one is medication, so androgenising drugs, in particular sodium valproate, or Epilim. So Epilim is used in a whole range of different scenarios now, whether it's for epilepsy or whether it's for mood dysfunction, and I think it's really not a good drug in young women, apart from the fact it's teratogenic. In around 10% of women exposed to valproate, they'll develop a polycystic ovary type syndrome. So they might have hyperandrogenism, hirsutism is fairly common, and the symptoms tend to resolve if you stop the valproate. So it's a handy one to know about. So I think this is quite useful from the toolbox. Certain investigations you would use to exclude secondary causes. I think it's pretty straightforward: a TSH, a prolactin, and an FSH if you're really worried about premature menopause. Some of the other things you might look at, if you're really worried about Cushing's, you could do a midnight salivary cortisol. I think that's probably the easiest screening test at the moment. Sometimes we look at DHEA. DHEA is an androgen made primarily by the adrenal glands. So it gives you an idea of these androgens, adrenal or ovarian in source. Sometimes I like to have a look at androstenedione, which is more ovarian in nature, but certainly these are not routine things that are recommended. The sort of classic secondary cause that everybody worries about excluding is non-classical congenital adrenal hyperplasia. It's certainly more common in specific ethnic groups. So it's not particularly common in Australia, but certainly you do see women of Ashkenazi descent, and even Italians have an increased rate as well. So in these particular groups, I would tend to do an 8am 17-hydroxyprogesterone, which is the screening test. It's usually done on day 3 to 5 of the cycle, or if they're not having regular cycles, just on a random day. And if the test is abnormal or not clearly normal, then you proceed on to further testing. Although the treatment from our perspective is basically the same as for the normal PCO, it does have implications for fertility treatment and also potential risk of congenital adrenal hyperplasia in any offspring, which can be quite a devastating condition. So I often get asked, well, when should you do all these tests? And it really depends what you're testing for. Some would say that you should be doing all these tests in the follicular phase. Not particularly critical if you're mainly testing androgens. So although there's a small increase in androgens around mid-cycle, it's not thought to be a clinically important increase. Timing is important I guess in a younger woman, if you're really wanting to exclude early menopause, ideally you'd look at FSH in the follicular phase. Another common question is, should the tests be done on the pill, or should you make women come off the pill in order to do the tests? So the pill does affect testosterone and SHBG levels. So it tends to decrease testosterone by around 50%, because it's basically switching off the ovary. So it turns off ovarian production, and the ovaries make about 50% of women's testosterone. It also increases SHBG and it suppresses FSH and LH. So you can check for testosterone and SHBG when someone's on the pill, but it's probably going to be quite different to if they're not on the pill. There's never any point testing FSH and LH on the pill. It's going to be suppressed and then it doesn't help you. Ideally, if you really want an accurate idea of what their hormones are doing, you get them to come off the pill for 3 months. But it's not always clinically appropriate. It's not always something the woman wants. So I don't think you have to do that. I think that's, if you're really concerned or it's really confusing, you can go ahead and do that. But I certainly wouldn't say that all women presenting with possible PCO who are on the pill should come off for 3 months. We know there's multiple associated conditions with polycystic ovary syndrome. So we know that obesity is very common. We know there's an increased risk of diabetes and hypertension, hyperlipidemia. We think there's probably an increased risk of endometrial carcinoma in older age because of unopposed estrogen. There can be fatty liver, there can be sleep apnea, and I know Mandy's going to talk more about the mood disorders. And of course, anovulatory infertility is what a lot of women are concerned about. This toolbox, I think, is probably the more controversial one. So when this was launched at the Endocrine Society some years ago, there was a lot of discussion, particularly about this recommendation for an OGTT every 2 years, because an OGTT is quite a difficult test to do on a regular basis. So I think it's reasonable that if you've confirmed PCO, you do test for diabetes, and you may want to do an OGTT as a baseline. I think that consensus would be, if that's negative, unless you've got a very high index of suspicion, that your follow-up ones, you could perhaps do a fasting glucose or an HbA1c. I think this is something, the diabetes screening is something that's probably going to be refined over the years. I think at the moment we have to go with the 2-yearly recommendation. But there seem to be quite a range of risks within this group of women. I don't think they're all at this terribly high risk. I think it's quite different if you've got a woman who's very obese and has a very strong family history of type 2 diabetes compared to a young woman who's 20, who's lean, who has no family history of diabetes. At the moment, we have the same recommendation for both of them, but do we want to have that young woman tested every 2 years till she's 50? You know, it's hard to know from the literature what is her actual risk of converting to diabetes in the next 2 years. So I think that's an interesting one. We also screen for lipids every couple of years, and there's some suggested targets here, which seem to align with sort of the old diabetes targets. I think the difficulty with screening for lipids, I do it, but whether you're going to start a statin is still really dependent on overall cardiovascular risk. So if you've got a 25-year-old with a cholesterol of 5 and no other cardiovascular risk factors, no one's going to start them on a statin. So it's still, although we'd have a lot of sort of suggested screenings and we do it, you still have to think carefully about what are you going to do to act on it. I think checking blood pressure annually, I think is very sensible. Particularly for women on the pill, etc. And smoking cessation advice is another screening that's recommended, which makes a lot of sense. So these are our overall screenings: 2 yearly for diabetes and hyperlipidemia, annually for blood pressure, and then with history screening for things like sleep apnea, which has been reported to be a lot more common in polycystic ovary syndrome, even in lean women, and seems to correlate with insulin resistance. Screening for mood disorders and smoking and alcohol use. I think alcohol is often not talked about, but I think it's very important because we know that particularly things like depression and anxiety are common in this group, and when you ask, a surprising number of women that seem to be treating their anxiety with a bit of alcohol at night time. So I thought I'd just run through what do I do in a standard consult, because often it's not really spelt out. There's no particular order, this is just how I write my notes basically. So usually I just give them a chance to say what they're actually there for, because I think with PCO it's like a lot of conditions, because we get stuck on, oh, we've got to screen for this and that. You sort of forget what they're there for, and they might really just want to be there because of, you know, actually it's their weight or something like that. Always ask about medications, particularly for things like valproate, but also what pills they're on and what they've tried. I think it's really important to discuss things like, do they need contraception? What are their plans for children in the future? Are they smoking? Are they on a special diet? So it's you know, a lot of people are on quite diets that exclude a lot of things. The family history, I particularly look for diabetes, PCO or infertility. For their own personal history, I'm particularly again looking for diabetes and hypertension. Did they have delayed menarche? And then specifically ask about the diagnostic criteria. So what's their menstrual cycle pattern? Have they been tracking it? A lot of women have those apps. Their acne and hirsutism. I think it's really important to ask with those sort of symptoms, when it started, is it progressing rapidly? So there's quite, most women that you see will say, oh, I probably started in my teens or my early 20s, and it's basically been the same, or it's a little bit worse than it was, or, you know, I put on 10 kilos when I went overseas and then it got worse, which is quite different to someone saying, oh, in the last 6 months I've developed a beard. You know, that's where you get worried. And then there's all the other symptoms you might want to ask about. So if you weight change when you're screening for mood. I often now screen for childhood trauma as well, because it's so common. And the physical, I put a lot of things here, but actually it's pretty quick. So, you know, their height and weight, you're having a look at their body habitus. If you're worried about things like Cushing's, you're going to look at, you know, do they have Cushingoid facies? Do they have a buffalo hump? Do they have striae on their abdomen? Where's the distribution of the acne and the hirsutism? How severe is it? I usually look for acanthosis nigricans as an indicator of insulin resistance. So that sort of purple, brown velvety pigmentation, usually on the neck or in the axillae. So it looks like a lot of things, but it's really just asking them to take their top off and having a quick look at their skin. And then looking at blood pressure as well. So I'm lucky. Usually they've already had all the tests done, and then we can make the diagnosis and discuss further. And there's a really good little patient information booklet that they're all really happy to get, which is great. Often, even if the tests aren't back, you can make a lot of the diagnosis or discuss the likely diagnosis. And I think with treatment, often I give them an overview of the treatments available, which really are these four. And then you've got to target it, I think, to their particular concerns. I don't think we've really got proof that apart from lifestyle, anything's particularly disease modifying. So I think really treatments are around, well, apart from if they've got amenorrhea and you need to give them endometrial protection. But apart from that case, I think it's really targeting around quality of life. You know, I don't think we've got a lot of evidence yet that starting any one particular treatment is going to make huge differences long term to any particular outcome. So I tend to focus management on symptoms, then if I'm worried about longer term risks, and then also there's a discussion of fertility. So I think lifestyle is often key to management of pretty much everything. The aim might be to prevent weight gain, it might be weight loss. I think often you can have a discussion and then people will indicate to you whether they're interested in knowing more or not really. Even 5% weight loss can be helpful in restoring menstrual cycles and ovulation. I try to push for a dietitian referral if women are really wanting to lose weight, particularly if they're wanting to get pregnant. The guidelines had quite a good look at all the diets available and didn't really find any one diet that was better than another, and suggested that to lose weight, women should aim for less than 5,000 kilojoules a day or less than 1,200 calories. So, which, you know, is not that much. There's some evidence from a few studies that women with insulin resistance may find it easier to adhere to a low carbohydrate diet. Doesn't mean a no carbohydrate diet, and I really advocate against a no carbohydrate diet because I think people feel much worse on it. If they don't want to go to a dietitian and they really want to know what the diet is they should be on, I tend to point them towards the CSIRO Total Wellbeing diet, just because we know it's a fairly well-balanced diet, and there's been one study in it showing that it may improve wellbeing in PCOS. So although one study is not the be-all and end-all, at least you're recommending something that, you know, is fairly balanced and going to make sure they get nutrition. But I think, you know, often they do need a bit more specific advice from a dietitian. The guidelines also make a recommendation for 150 minutes of moderate or vigorous exercise per week, and of course focusing on smoking cessation. In terms of non-medication therapies or topical treatments, I think laser hair removal is really one of the most effective treatments for hirsutism, particularly on the face. Although it tends to be most effective if you've got dark hair on light skin. So if it's dark hair on dark skin, not necessarily going to be that effective for you. So for women who can afford it, I think laser is a good option, so long as they've got access to it and to medically supervised laser therapy. I think there's a lot of sharks out there that do it as well. Vaniqa cream can be used to prevent regrowth of hair, but very few people I see will use it because it's so expensive. And then there's, you know, all the things that you know a lot more about than me in terms of acne management as well. So first-line management pharmacologically for PCOS generally being the oral contraceptive pill. We know it's got multiple advantages, so it helps control the menstrual cycle, it provides you with endometrial protection, it's contraceptive. We know that it reduces testosterone around 50% and increases SHBG. And we know that after around 6 to 12 months, it can improve the symptoms of androgen excess, so things like acne and hirsutism. Of course, there are all the other concerns with the pill, such as DVT and stroke, although their absolute risk is small, and it may worsen insulin resistance. So I think the pill is useful. I don't think everyone has to be on the pill. I think some people get the idea that if you've got PCO, you have to be on the pill, and if you won't be on the pill, then you're a bad patient. I don't think everyone has to be on the pill. I think there's a lot of women that cannot tolerate the pill and shouldn't be made to go on it. Other options, which is if you still need contraception but you can't take the pill, obviously things like the progestin-only pill and the Mirena, which will also provide endometrial protection, or in someone with amenorrhea where you are worried about endometrial hyperplasia, you could use a cyclic progestin, aiming for 4 bleeds a year. There's been a lot said about, well, what's the best pill to use? And I find this a really difficult question because the pill has so many side effects and it's so unpredictable as to who will get that side effect. So usually it's trial and error. We've got, in terms of skin, it's often been said that you should pick a pill that has an anti-androgen or a low androgenic progestin in it. So we know that certain pills, particularly the ones on the PBS, the progestins are derived from testosterone, so they tend to have androgenic effects, whereas these other newer ones tend to be anti-androgenic or just have a low androgen profile. I think there's pros and cons. You still can use your normal PBS-funded pills. They will still reduce testosterone concentrations, and they are still effective at reducing hirsutism and acne. They also have a lower risk of VTE associated with them and have been used for a longer period of time, so I think the side effects are better known. The ones, asterisks, are thought to have a significantly higher risk of blood clotting compared to, say, pills containing levonorgestrel. The ones without asterisks haven't been around long enough to really know what their clotting risk is. So I think that I think it means that you don't have to jump into one of these, particularly if money is an issue. You can start with one of these, and I think the pill is about considering the overall risks and symptom profile and what women want overall. And often it is very difficult, and it depends on what they've used in the past and what you think is going to help them the most now. So it's not easy. We sort of covered this already, but certainly you can use progestin-only therapies. What about metformin? So this is another line of therapy. It's debatable whether it's weight neutral or maybe result in a small degree of weight loss in some women. It can prevent weight gain associated with the pill. There's been quite a nice trial to show that. Certainly useful in preventing conversion of glucose intolerance to type 2 diabetes. We don't know, we presume that if you're at a high risk because of PCOS, a high risk of diabetes, that metformin will reduce that risk, but we don't actually have the studies to say that explicitly. It can be useful in helping restore menstrual cycles, so sometimes I use it in women who really do not want the pill, who can't tolerate synthetic progestins. It's not that effective in doing it, but maybe in 40% of women it does help restore their cycles, and it's a non-hormonal way of doing it. It's no longer recommended as a first-line therapy for fertility treatment, so although it does restore ovulation, in the reviews it didn't actually increase the rate of live births. So although it can still sometimes be used, it's not a particular go-to drug for fertility anymore. I tend to start at a low dose and increase slowly and use the XR version. It's marginally more expensive but has less nausea associated. It's important to know that it can decrease vitamin B12 levels, so I would usually check if I'm going to use it, I would usually check the B12 when I'm doing their initial screening, and then perhaps intermittently thereafter with other blood tests. This is generally how I would use it, and there's different approaches, but basically starting with a 500 milligram tablet and then increasing every 2 weeks by 500 milligrams up to the maximum tolerable dose. So I think everyone should I think aiming for the maximum dose is good, but certainly no evidence to say that you have to get to the maximum dose, so it's really just what dose they tolerate. This is for normal, so you can use it in women without impaired glucose tolerance. And really then you're using it to help with their cycles or help manage their weight. So often it does help, particularly if they're already doing lifestyle things, it can help make it a bit easier to manage their weight. It does have a small appetite suppressant effect. So that's sort of where I use it. If they're at a very high risk of diabetes, then that's where I'd be using it as well. Anti-androgens are another group of drugs that we use. So it's recommended that anti-androgens are added in if after 6 months on the pill they're not seeing the response they want in hirsutism or acne. It's harmful to a male fetus, so the recommendation is that there's adequate contraception and that you exclude pregnancy before using them, and definitely stop them if pregnant or breastfeeding. I think the most commonly used would be spironolactone. Standard dose would be 100 milligrams, but up to 200 milligrams can be used. The side effects I tend to mention are, it's a diuretic, so it makes people run to the bathroom. It can, if someone's not on the pill when they're on it, it can cause menstrual irregularity, which is, apart from contraception, is another reason why it's usually co-prescribed with the pill. It is an antihypertensive, so occasionally women get a bit dizzy when they first start it. And it's potassium sparing, so you need to be mindful if they're on other antihypertensive agents that may affect potassium, or if they're on supplements, and it's usually worth checking their potassium after 3 to 6 months and their UECs. Cyproterone acetate's another one that's used. It comes in 50 milligram tablets on the PBS, and you can either start with 50 and then when you've had effect reduce to 25, or you can start with 25, and it's usually given for the first 10 days of the pill. In terms of fertility, not all women with PCO end up needing fertility treatment. Some of them might actually be having regular cycles at the time, or they may be ovulating, and you can check that with the day 21 progestin. I think from a non-fertility group, weight management is important, but I'm keen on early referral to a fertility specialist if they want to get pregnant and there's any concerns. And Clomid's the first line treatment. And often, I think when women are referred to me, there's a lot of, even if they're quite young, there's a lot of anxiety around fertility. And I think it's helpful to know that on the Australian data, women with PCO end up having the same number of children as women without PCO, and that not everyone with PCO needs IVF, that quite often it's no fertility treatment or it's fairly simple fertility treatment like Clomid that's required. I know that mood's going to be covered in a lot of detail later on, so I just thought it was worth mentioning that a lot of the treatments used in PCO can exacerbate mood problems in a subgroup of women, so certainly not all women. We know that cyproterone acetate can precipitate depressive symptoms, and we know that some women are quite sensitive to progestins. So I think that's just an important part of the history. If they've had negative reactions to a lot of pills, they probably will again, so that does make it more difficult too. And this is a really nice summary slide from the toolkit, which really summarises all that information in one page.